Welcome, dental faculty. We're diving straight into this explainer session on demystifying and designing modified essay questions, or MEQs. If you're a clinical teacher wanting to truly transform how we evaluate candidates and, make absolutely sure they're genuinely safe for clinical practice, well, you're in exactly the right place. Let's break this down.
So here's our quick roadmap for today. We'll start with Act 1, the what, move into Act 2, the why, jump into Act 3, the how, and wrap up with some common pitfalls to avoid. All right, let's kick things off with Act 1, the what.
Now, right off the bat, don't let the name fool you. It's actually not a single long essay. An MEQ is really a dynamic, unfolding clinical scenario. Think of it as a linked chain of focused, short answer questions that follow just one patient. And the beauty of it is that it demands active application of core knowledge at every single link in that chain. You can kind of see it as the missing link or the active reasoning bridge in our assessment toolbox. On one side, you've got standard multiple choice questions. They're great for breadth, sure, but they mostly test superficial recognition. On the other side, traditional open essays can honestly suffer from low grading reliability and, let's face it, allow for a lot of tangential rambling. So the MEQ sits perfectly right in the middle, blending structural constraints with constructed, thoughtful responses.
And this isn't some experimental new fad. This proven instrument was actually pioneered way back in 1975 by Hodgkin and Knox. They developed it specifically for the Royal College of General Practitioners in London to standardize primary care assessments. Fast forward to today, and it's continually evolving in modern medical and dental exams to rigorously evaluate clinical competence. Moving right along to Act 2, the why. So, why go through the effort of designing these? Well, first off, MEQs compel students to operate at a much higher cognitive level, specifically targeting Bloom's Level 3 reasoning. We're talking synthesis, evaluation, and problem solving. Plus, they simulate the true chronological uncertainty of a real dental clinic. Patient data is revealed progressively, so you're actively testing a student's index of suspicion in real time. And here is a pretty wild fact about standard exams. Standard MCQs carry a built-in 20 to 25% guessing factor. A student might just get lucky or use the queuing effect to recognize an answer they couldn't actually come up with on their own. But with MEQs, because they require constructed written responses, that guessing factor is virtually wiped out. You get to see exactly what the student actually knows. On top of that, when students know they'll be tested this way, it creates this massive positive washback effect. It literally drives them toward deep learning strategies instead of just rote memorization. And from our perspective as examiners, this format gives us a highly reliable bell curve. We can confidently discriminate candidate maturity, easily separating the safe prospective practitioners from the unsafe ones. Okay, let's get into the mechanics. Act 3, the how. Imagine a totally standard clinical scenario. A patient walks in presenting with facial swelling. This becomes our running case anchor. We are going to follow this single patient saga from the very moment they sit in the chair all the way through to the final treatment plan. The absolute cornerstone of this whole design is sequential disclosure. Information has to be revealed in strict chronological stages. You enforce this by using physical booklet pages that are collected one by one, or through digital locks in a computer-based test. Doing this prevents what's known as backward queuing, meaning students simply cannot look ahead to future pages to find clues for their current diagnostic questions. Structurally, the design is super precise. Step 1, you provide a brief, highly focused clinical vignette. Just give them the raw data they need right at that moment. Step 2, you follow it up with telegraphic sub-questions. We want bullet points, specific diagnoses, short lists. No long prose allowed. This constraint is exactly what makes MEQs so efficient and keeps your grading highly objective. Now, the true elegance of the MEQ format is how it handles integration. Think about our single facial swelling case. We can seamlessly weave together multiple disciplines in one continuous exam. Stage 1 might cover endodontics for the initial diagnosis. Then Stage 2 could bring in periodontics and prosthodontics for treatment planning. You could even throw in a stage specifically testing patient communication skills. It really is holistic assessment at its finest. Of course, grading these requires a really solid hierarchical rubric where you define essential versus desirable points. But here is your ultimate safety net, the killer question. This is a specific rubric threshold where a clinically dangerous action, like, say, prescribing a heavily contraindicated drug, triggers an automatic score of 0 for that section. It's a fantastic way to ensure we maintain rigid patient safety standards.
Finally, let's wrap up with some common pitfalls to avoid.
It is absolutely critical to know that writing flawless questions is tough. In fact, according to psychometric literature, item writing flaws are actually more prevalent in MEQs, sitting at about 16%, compared to 12% in MCQs. This usually happens simply because faculty aren't quite familiar with the strict structural rules of the format, which is exactly why we're doing this explainer today. So to prevent your MEQ from structurally failing, you've got to run a quick self-check. First, avoid reverting to simple rote recall or basic list making. Keep pushing for that Bloom's Level 3 reasoning. Second, make sure you don't create rigid progressive blockages where an early mistake penalizes the student over and over. Always give them a clean slate at the start of a new stage. Also, avoid ambiguous stems like, what would you do? Be specific. And finally, double-check that your grading rubrics are standardized and you've cut out any superfluous repeated information. But the absolute most dangerous flaw? That would be cascading stems or backward queuing. As an illustrative example, imagine stating, the patient's hemoglobin returns at 10.4 grams per deciliter, confirming microcytic anemia. If you inadvertently provide this diagnostic data in Stage 2, well, you've just accidentally handed them the answer to a Stage 1 question. You absolutely must lock the doors behind them.
I want to leave you with this core philosophy as you empower the next generation of safe practitioners. A good MEQ tests thinking, not recall, and locks the door behind each step. So as you look at your own syllabus today, what is your first locked door going to look like?